Here's our roadmap for today. We'll be covering how anatomy defines the surgery, the strict 5 centimeter rule for rectal cancer, adjuvant therapies beyond surgery, handling emergencies and fast-track recovery, and finally, anal cancer and the legendary Marrow regime. Section 1. Anatomy defines the surgery. Okay, to understand how we cut, we first have to really understand the plumbing. The colon isn't just some simple tube, right? It's this complex structure with a very specific and honestly, sometimes vulnerable vascular network. Think of these watershed regions as the vulnerable far ends of a plumbing system. You've got the Griffith point up at the splenic flexure and the Sudeck point down at the rectosigmoid junction. Because the blood supply in these highly specific areas is inherently weak and dicey, surgeons have to be incredibly careful. When they remove a tumor and stitch the remaining healthy bowel back together, a process called an anastomosis, they have to ensure those newly connected tissues have enough blood flow to actually heal. You literally cannot risk connecting bowel at a watershed point with a fragile blood supply or the whole thing could fall apart. And this brilliantly illustrates how tumor location completely dictates our surgical action. You see, lymph nodes, which are exactly where cancer tends to spread first, lie directly along these blood vessels. So to get at least 12 lymph nodes for a proper oncologically sound cancer resection, you actually have to take the vessels themselves. If a tumor is sitting over in the cecum, surgeons perform a right hemicolectomy, ligating branches of the superior mesenteric artery, like the right colic and ileocolic arteries. But if the tumor is on the left side in the descending colon, they do a left hemicolectomy. That means performing a high ligation of the entire inferior mesenteric artery. The anatomy literally draws the surgical map for us. Section 2. Rectal cancer, the 5-centimeter rule. Moving further down into the rectum, the surgical math gets incredibly tight, and the stakes for the patient's daily life get incredibly high. It all comes down to one absolutely crucial number: 5. Specifically, 5 centimeters from the anal verge. The anal canal is only about 4 to 5 centimeters long in total, and it houses the internal and external sphincters, the exact muscles that keep a person continent. This single number dictates the entire surgical approach. So here's how it plays out. If the tumor is more than 5 centimeters up, we usually have enough room to cut below the tumor, but above the sphincters. This is called a low anterior resection, or LAR. The sphincters are saved, a circular stapler is used to reconnect the bowel, and the patient remains continent. Huge win, right? But if the tumor is within that bottom 5 centimeter zone, saving those sphincters is usually just impossible. In that case, 2 surgical teams, one working from the top through the abdomen and one from below the perineum, have to meet in the middle to perform an abdominal perineal resection, or APR. The entire anal canal is removed, and unfortunately, the patient will require a lifelong permanent end colostomy. Now, regardless of whether a surgeon goes with an LAR or an APR, there's a golden rule we have to follow, established by a pioneering surgeon named Heald. The mesorectum, which is the fat surrounding the rectum that harbors hidden lymph nodes, must be completely cleared out to prevent a high recurrence of cancer. This is called a total mesorectal excision, or TME. Fascinatingly, though, surgical techniques are always advancing. We now have things like TATME. This is a minimally invasive, natural orifice procedure where surgeons enter directly through the anal canal to clear the disease for early T1 or T2 tumors, entirely avoiding major abdominal incisions. It's a real game changer. Section 3. Beyond surgery. Adjuvant therapies. Because let's be real, surgery is often just one piece of the toolkit. For a lot of patients, we have to bring in the heavy systemic medical artillery. Now here is a hard and fast clinical rule you're definitely going to want to lock in. Radiotherapy belongs exclusively to rectal cancer management. It can be given as a short course or a long course, often combined with chemotherapy to shrink a tricky tumor before we even operate. But listen to this. There's absolutely zero role for radiation in colonic cancers higher up in the tract. None. Chemotherapy, on the other hand, bridges both colon and rectal cancers. When a patient has positive lymph nodes, advanced T3 or T4 disease, or metastasis, we rely on heavy-hitting regimens like FOLFOX, FOLFIRI, and CAPOX. But modern oncology goes way further now with immunotherapy and targeted agents. We use bevacizumab to literally choke off the tumor's blood supply by targeting VEGF. We use cetuximab to block epidermal growth factor receptors. And for patients who have microsatellite instability, which we often see in genetic conditions like Lynch syndrome, we actually use PD-L1 inhibitors like pembrolizumab. This effectively unleashes the patient's own immune system to hunt down the cancer. We can talk about these highly potent, toxic therapies all day, but the source material we're looking at pauses for a really powerful moment of empathy that I think we need to highlight. The instructor recalls taking a brutally choppy boat ride off the coast of South Africa looking for whales. The severe, relentless seasickness he experienced finally made him truly understand the crippling nausea his cancer patients endure every single day. It's a vital reminder for all of us. Behind every single regimen of full fox or full fury is a human being enduring immense, crushing physical hardship. Section 4. Emergencies and fast-track recovery. Right. So sometimes, unfortunately, patients do not have the luxury of planned, nicely scheduled treatments. They present in the middle of the night to the ER with a completely obstructed bowel. Imagine you're a junior resident facing a midnight emergency, obstruction caused by a massive tumor. You can't just do a complex textbook resection right then and there. You have to relieve the blockage safely. A common approach is a diverting colostomy. But if you close off the disconnected lower bowel and just leave it inside, which is known as Hartmann's procedure, you run a massive risk. The tumor is still in there and it's secreting mucus. Because the tube is blocked, that mucus can build up, burst, and cause a lethal perforation. A much, much safer bet for these emergencies is the Paul Michaelich surgery. This brings both ends of the bowel outside the abdomen. The lower end basically acts as a mucus fistula, allowing completely safe drainage until a senior surgeon can come in and properly remove the tumor later. Okay, so once an emergency or even a planned surgery is done, how do we actually get these patients better faster? Enter the ERAS protocol, Enhanced Recovery After Surgery. We are totally ditching old surgical dogmas here. Instead of starving patients before they go under, we do pre-surgical carbohydrate loading. We start feeding them basically immediately after surgery. We avoid unnecessary nasal tubes and abdominal drains. We get them right out of bed and walking early, fully supported by adequate painkillers. It's a complete paradigm shift aimed at rapid physiological recovery. And in what is honestly a massive win for modern surgery, our approach to metastatic disease has shifted drastically. The liver is the most common site for colorectal cancer to spread. Now, the old rule used to be that you could only operate if there were fewer than 3 tumors confined to one lobe. Well, not anymore. The new guidelines state that the pure number of metastases doesn't actually matter. As long as the tumors are anatomically resectable and you can leave the patient with at least 25% of their functional liver reserve, or FLR, you go in and operate. Resecting these liver metastases significantly improves patient survival. Section 5. Anal cancer and the Marrow regime. Finally, let's look at the very end of the GI tract, where the biological rules we just talked about completely flip on their head. Unlike the colon and rectum, which are lined with glands that form adenocarcinomas, the anal canal is primarily lined with squamous cells. Because of this, anal cancers are overwhelmingly squamous cell carcinomas. And the risk factors? Totally different. They are heavily driven by viral infections, specifically the human papillomavirus, or HPV, and are frequently seen in immunocompromised individuals, like folks who have recently had organ transplants. Now, because this tumor sits directly on the sphincters, cutting it out immediately means an automatic abdominal perineal resection and a permanent colostomy bag. To avoid this life-altering outcome, the legendary Negro regime flips the script. Instead of doing surgery first, we hit the tumor with 1 solid month of combined chemo and radiation. Then we wait and we monitor. In many cases, the tumor literally melts away entirely, and the patient gets to keep their sphincters intact. We keep surgery, that radical APR, strictly as a last resort, used only if there's residual or recurrent disease. From carefully navigating those watershed arteries to sparing the sphincters entirely with the Negro regime, the management of GI cancers really is a masterclass in precision under pressure. As our techniques continue to evolve with incisionless transanal surgeries and rapid ERAS protocols, we aren't just focusing on survival anymore, we are heavily optimizing for human dignity. And as these therapies become even more precise and targeted, it leaves us with a profound question. How will we continue to redefine the very limits of recovery and quality of life for cancer patients in the next decade? Thank you so much for joining me for this explainer. Keep learning, and I'll catch you next time.